All right, so here's what we're going to learn now. The most important skill that you have as a psychiatrist, mental health professional, counselor, whatever you end up being, PA, physician, no matter what specialty you're in, is to be able to do an interview well. All right. That's like your first thing that you're going to do with the patient is interview. Unless you're a trauma surgeon. You're probably not going to interview them that much. Can you hear me? No, I was kidding. Open your eyes. That's about the extent of their interview. But for us, since we typically don't have a lot of tests and stuff like that, you got to get really good at the interview. It's like our most powerful tool, most useful tool. And if you do it right, your most effective tool. All right. So I want to walk through some, like, as far as I can, like a master class on how to do an amazing interview. All right. So y'all see me interview patients. Sometimes I put my heart in it. Sometimes I kind of have to, but I can always get the information out of the patient that I want. Okay. I believe that comes from that initial interview and how I conduct it, so that the whole relationship going forward has a standard. Right? So I don't like to brag, but I'm pretty good at this. Okay, I'm gonna teach you how to be pretty good at it. All right? I'm sure there's people that's better at it. I'm sure there's people that's gonna disagree with how I do it, but I think this is like the best one. If you can master a psychiatric interview, you can do an interview on any rotation. Right? It's gonna be like a microcosm of the psychiatric interview. Is that really that hot? Is your coffee really that hot? Really? The hot water in the thing?
Yep.
Well, shoot, let's go. I know mine is kind of lukewarm. I gotta have the coffee. Okay. All right. So what I'm gonna try to go over is one, I want to go over kind of like the core principles of your psychiatric interview. Okay, I'm gonna do that. Two, I want to talk about like rapport building. Like how do you get like a comprehensive history out of a person? Because you only got an hour. You got an hour to do everything for psychiatry. Other specialties, you got less time. Then I'll give you some strategies. How do you manage like a difficult interview? You're gonna get those, like patient not talking enough, patient talking too much, patients being confrontational, like dealing with your own feelings. Oh, I don't want to be rude, right? So I want to tell you how to kind of manage those things, and then if we have time, we'll talk about like how do you like apply it to like work, so that you take this interview and turn it to an effective treatment plan. Because it all like ties together. The way you construct your interview will directly affect your ability to create the treatment plan. All right. So this is especially important for you because you're going to get thrown in the fire soon and start seeing patients, and you may or may not have been taught this interview process this way. But this is kind of my expectation. So I'm gonna poll the audience. What are the objectives of that first interview? What are your objectives? Like it's a mission. Like if you don't know your mission, like objectives, then you can't accomplish your mission. So what's the objective?
Addressing the chief complaint.
Okay, you said elicit the chief complaint.
Elicit or address the chief complaint, yeah.
Okay, elicit or address the chief complaint.
Build rapport with the patient.
Building rapport with the patient. Good answer. Good answer.
Find out how you can help the patient, what their patient is here for.
Right. So finding out what the patient is requesting, so you can figure out how to help them.
How to treat.
Okay. Good answers. All good answers. So to keep these random things float around your head, we got to boil it and distill it down to what it actually is. One, the mission objective is, in my opinion, number one, is to build therapeutic rapport. That is the foundation of your whole relationship with the patient. Because you can know all the facts and the patient not like you, and they won't listen to you or they won't come back. Okay? So in my opinion, the foundation of your whole relationship is building that therapeutic alliance and therapeutic rapport. So that's objective number one. Objective number two is gathering accurate diagnostic and historical information in a time frame. Okay, that's the objective. Because I can get all the history in the world, but it might take me 4 hours. You don't got 4 hours. Okay. In my opinion, what should be in the back of your mind is that I'm truly listening, not just hearing. Because a lot of doctors hear, but they don't really listen. Here's how I know. This happens when I go to my doctor. Hey, how's everything going? Yeah, Click, 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 click. Trying to listen to my heart. I gotta stop my sentence because you're telling me to breathe. You hear me, but you're not really listening. You're trying to get through my appointment so you can get to the next person because you know you got 30 more people to see today, right? In psychiatry, in my opinion, you have to be a very astute listener because everything means something. So what's said is important. Also, what's not said is important. And as you get experience over time, you'll notice that, I asked this question and they didn't even address this. That means something, right? Also, the observation of the patient means something. How are they dressed? How are their nails? What type of shoes they have on? How do they shake my hand? How do they sit in the chair? Etc. So all that means something. And as you work with people, you'll be more aware of what those things mean, right? So you got to be an excellent listener, and you must have excellent observational skills to get the most information. Because what I'm doing, I'm information gathering. Because the more information and the more accurate information I have, the better treatment decisions I can make for that patient. Okay, so that's an objective for you. So, in my opinion, the building blocks of your interview are one, the therapeutic alliance. We talked about that. Two, you got to have like a framework of how you understand your psychiatric, diagnostic, semi-structured interview. So you gotta have a framework, because if you just start having a random conversation, you won't get all your pieces. So you gotta understand that framework, and I'll kind of go over that today. The other building block is having an effective way of asking questions, right? So sometimes, here's a quick example. If I'm asking about a sensitive topic, and I want to know your sexual history, and I want you to be truthful, right? If I say, oh, how many sex partners have you had? First thing you're going to be like, right? Either you're going to minimize it or you're going to maximize it, right? Based on how it made you feel, right? So there's ways to ask a question to make people comfortable so they can give you accurate information. So effective questioning strategies and techniques is a foundation. And then 4 is your clinical presence. How are you emoting? What is your body language telling the patient, right? It means something very different if I'm interviewing you and I'm doing this. All right? That's going to make you feel a different way than me just like not writing. I'm just looking at you. I'm emoting to what you're saying. I'm leaning in. I'm nodding my head. I'm asking you clarifying questions. Now I'm engaged. It makes you feel different. So your clinical presence is a foundation of how you conduct this interview. Okay. So you get all 4 of those: therapeutic alliance. What did I say? Framework of your understanding of how to conduct the interview. Your question style, like your technique to ask the questions, and then your clinical presence. Those are your building blocks. Okay. So let's walk through, in my opinion, how an interview should be structured. All right. Now, this will be slightly different for telehealth because you won't have all these pieces. So, in my opinion, part 1 is observation. Observation. Okay. So the observation phase, in my opinion, is all the data you can collect before you actually directly interact with the patient. To me, that's like visualizing the patient in the waiting room. What's their behavior? How are they sitting? Are they completely relaxed and chilling? Are they, shaking like a leaf, looking around, looking paranoid, rubbing their hands, right? Are they on their phone, indifferent? Who are they sitting with? Are they with their spouse? And they cuddled up like cuddle bugs? Or you don't even know they're sitting by themselves, the spouse sitting over there, and they come back and they both come back like, where did you come from? Might mean something different. What kind of shoes they wear? I really like pay attention to people's shoes. Especially if it's children and the child is the identified patient. and they're oppositional to defiant, and they bad, and they parents complaining they got in the new Jordans that cost $250. That tells you something about that family dynamic, right? You know, fingernail lift, hair lift, stuff like that. I'm gathering information about what I'm about to walk into, right? Are they talking super loud in the waiting room or over talking to staff? I'm getting information. I'm observing that patient, so I know how I need to conduct my interview, right? And things to listen out and look for. That's step one. Step two, and I don't know why I'm using colons. Don't judge me. Okay. I think it's the greeting. I think you should be very meticulous about how you greet people. It's your first impression that you're presenting to the patient that goes back to your clinical presence, right? A lot of people are thinking, man, you can think about it. Patient's in the waiting room. Mr. Smith? Hi, I'm Dr. DeBose, let's go. And you just walk back. To me, that's an ineffective greeting, right? The purpose in my mind of the greeting is to set the stage of what type of person I am and then how much I care about you and I just met you, right? So I want to look the person in the eye, I want to call their name, look them in the eye when I meet them, and I'm observing something I can comment about for that patient because I'm trying to build rapport. So if their hair's purple and purple's my favorite color, oh my God, your hair's beautiful, purple's my favorite color. I'm Dr. DeBose, how are you doing? And I'm gonna shake their hand, right? And I do the handshake for two reasons. One, obviously it's a sign of respect because that's a cultural norm. But two, I'm assessing the quality of their handshake because it means something, right? For example, if I shake a man's hand, he tries to crush my hand, that means something very different. If I shake a man's hand, he kind of give me a limp noodle. See what I'm saying? Do you agree with that?
Yeah.
Yeah, definitely, right? So it means something different. Even with a woman, sometimes I shake a woman's hand, and her handshake is so freaking strong. I'm like, holy cow, girl. Dang, girl. But that may infer her worldview or how she was trained or her parenting or her military background. Everything means something. That's how I want you to think about an interview. Everything can mean something, right? And as you see more and more patients, you'll start seeing patterns. You'll see patterns. I can't teach you all the patterns. Only experience can teach you that. But if you're thinking like everything means something, you'll start picking up on the patterns, right? So my greeting, I'm saying something, I'm observing. Sometimes I want to make a comment about them or something I want to say for later. I want to ask about, all right? I'm going to shake their hand. I'm looking in the eye. I'm going to welcome them. Thank you for being here today. All right, come on back to my office, all right? I'll lead them back to my office. I've already predetermined where they're going to sit at. What's up?
I need your signature, please.
Gotcha.
Right here.
Muchas gracias.
Yeah.
So I'm gonna bring it to my office. I've usually already predetermined where I want them to sit. Okay. If you have options in your office. The reason for that is I want to create an environment that does not create a confrontational type of arrangement in the office. So a lot of people don't think about this. But for example, I never like to sit directly across from a patient because think about it, when you're about to fight, where do you get? You get directly in a person's face, right? It's a confrontational position. So I always like to be off center from a person because it's less confrontational, right? That's more important to some people than others, right? But typically I don't like organize the room in such a way, like how our conference room is right now. I typically won't sit here and have the patient sit right there, right in front of me. If I do, I'm going to slightly make my chair off center. Very small detail, but it decreases confrontation between you and the patient. Okay. So usually, since I've already predetermined where I want them to sit, I'll lead them there. Hey, have a seat here. Blah 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 blah. I'll send them where I want them to sit. If they have family members, I'll place them where I want them to, because I've already observed the dynamic in the room. So if the wife and the husband clearly don't like each other, I'm gonna put some space in between the two when I come into my interview, right? So everything means something, right? So to me, the greeting is that first impression. 3, and this could probably be part of, let me get my pen. This could probably be part of the greeting. And I'll put this as 2A. Is the welcome. To me, a welcome is important. And I promise you, this will slow you down, but speed you up at the same time if you do this stuff. Okay? I do a welcome, especially for a new patient I've seen before. Because I've learned that if you give cheerfully and receive gratefully, everybody's blessed. So I want them to know that them choosing my practice, you're going to benefit and I'm going to benefit. So I'm grateful that they're here. And I acknowledge that straight to back. Thank you so much for choosing my practice. You could have went anywhere else, but you chose to come here. And I want to honor that decision so that this time that we have together will be meaningful for you and that we leave today with the foundation of some things that can help you. You know what I'm saying? Just saying that thank you in some type of way to the patient. And some patients, they don't care. Yeah, whatever. Okay. Yeah, that's cool. But some patients really appreciate the fact that you told them, thank you for coming. It's a really small little thing that you can do to start building a rapport. And you also know your posture. So the posture, in my opinion, that you want to have as a clinician is a posture of servitude. I'm a servant. Because you think about it, Jesus manifested. So God manifests himself as flesh, God being all powerful. He could have came as a king and just subdued everybody, but he came as a servant. It's a perfect example of how you should be as a clinician. You're a servant. You're in a service industry. So I want to put myself in a posture. I'm here to help you. And it needs to be communicated, and I do that through my welcome. Okay? So now they know, man, I'm in a safe place. I have someone that actually cares. I have someone who's very kind. I've never had a doctor say thank you for being here and take his time to do that. He made a comment about me. He's very observant, right? I'm giving them facts about me through this first part of my interview, okay? Because the rest of the time, I need facts about them, right? Does that make sense? Okay. So from there, now we're kind of getting to the bread and potatoes. This is my intro. My intro. And I call it framing. There's probably a real word for it. I don't know. My intro is my segue into my actual interview. So a lot of people bring people back to the office, have a seat. All right, so what brings you in today? And they start talking. Right? And they made my opinion, they made a fatal mistake. Now you have no control over the interview. You didn't set any parameters to the interview. The patient don't know what you actually want. They just know what they want to tell you. Right? It may or may not be what you're trying to hear. So now I need to introduce what we're about to do today, why we're doing it, why are we doing it, and what are the guardrails for what we're doing. Okay? I call that framing it. Right? So I'll say, after I, so thank you for being here. I'm trying to think through my script. You've been here. So today, my objective today is to really get a good feel for what you've been going through. So together, we can make some decisions of how to help you. So now to the purpose. The purpose is, I'm here to help you. You need to tell me what's going on, and I'm going to give you some solutions to get out of the problem. Telling them the reason why you're here. I'm giving them the agenda. So today I'm going to ask you some questions about your life experience. I also will talk to you about some of the past things you tried to solve this problem for yourself. Okay. We only have about 45 minutes to talk today. So I'm going to pause there. So I want to pause there to point out, usually intakes are an hour. This is for our practice. Whatever amount of time you have at your practice, you always tell them that you have less time you actually have. I do that so I can put some time pressure on the patient. 2, so if I do use all my time, they feel like they got extra time. And then 3, I need a justification for interrupting them when they talk too much. So today we're going to talk for about 45 minutes. And to go through your story and to go through your history, there's a lot of information I'm trying to gather. So there may be times where I have to interrupt you to make sure I get the details that I need to make some decisions for you. Now you're just giving yourself permission to interrupt them when they talk too much. So another thing I may do is I give them visuals to let them know I need them to stop talking, right? So I'll say, because we only have 45 minutes, then maybe times when I have to pause you. I do that for two reasons. One, so I can clarify and make sure I understood what you said. And two, to make sure you don't run out of time before we can make some decisions. Okay? The reason I always do this, and I always use a prop, okay? If I have my phone on the desk, I'm going to use my phone. I'm just going to pause you, okay? Because everybody in America understands, that I need to stop Netflix because I got to poop. Let me pause it, all right? People understand that motion, and they'll almost automatically stop once you do it in the interview, okay? So, and I've also forewarned them because, a lot of times people talk too much, and you don't manage your time well because you feel bad for interrupting the patient. They might be telling the saddest story ever, and you're looking at the clock like, oh crap, I'm not going to get to my substance abuse history because I'm going to run out of time, but you don't want to stop them, and then you don't get all the information you need to make a sound decision. So now I've set a framework that I'm going to pause you periodically necessary, okay? Most people will accept that limit, right? So now I'm kind of structured. I told them what we're going to do, what our purpose is. I've told them what the ultimate objective for me to come up with a treatment plan. I've already built some rapport with them, right? I gave them a time limitation to put time pressure on them. I've given myself the tool I need to shepherd the conversation with my pause button, okay? Now I got to transition to kind of my kind of safety parameters I need for the visit, right? One is confidentiality. So this is all in my intro. So I have my confidentiality statement. So I tell them, now everything we talk about here is confidential. Nothing leaves this room without your written permission. So if you want a family member involved in your care, you have to sign a release for me to talk to them. However, my first duty is to keep you safe. And in certain situations, in my duty to keep you safe, it may breach your confidentiality. If I'm concerned that you're at imminent risk to kill yourself or kill someone else, it's my obligation to protect you and to protect the community. And that may breach your confidentiality. Otherwise, it's like Vegas. What happens here stays here. And people go, ha, 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 ha. Or they say, oh, God, he's corny. Whatever. But I did my confidentiality statement. And they know that what my duties are. So you got to say that. Okay. One thing you don't want to do is have to hospitalize somebody and then they're pissed at you because they didn't know that was a possibility and they never come back. So you can't help them. That's happened to me before. Right? So I'll tell them the confidentiality statement. Now I've set the foundation and the framework for the interview. Okay, now I got control. Right? Otherwise, you don't have control of the interview. Now you're going to segue into the interview proper. So this is what you actually been trained on. So to do this, it's going to take you about 3 to 5 minutes to do all this. But it's your best invested 3 to 5 minutes for the interview. It also makes the patient not feel rushed when you do this. All right. Now they're set. Now I'm going to move into what's called a downward funnel. You heard of that, right? Okay, what's a downward funnel?
It's
Isn't that like a writing style or something?
Nope, it's not a writing style.
Oh.
That's a good guess, though.
I don't know. I thought I heard it was like a catch-all, so like you.
From general to specific?
Very close. From general to specific, do you have any ideas of what the downward funnel is? Okay.
I was gonna say, broad to narrow in the topic of.
So the downward funnel is a questioning style. Question. Can I spell that right? Probably not. Question style. So the downward funnel is a question style when you go from open-ended questions to more closed-ended question to try to control the quality and the content that's coming out of the client. Okay? So open-ended questions encourage kind of free responses and narrative style answers. Right? So if I say, so tell me what's been going on in your life that made you decide to make this appointment. That's an open-ended question. I can go even more open. Tell me, I can say, so what brings you in today? They can answer anything. My car. People said that, right? They can answer anyway. So the more open-ended question, the more possibilities of what they can tell you. It encourages the narrative and it encourages the patient to answer any type of way. That's what I want in the beginning, right? So I want you to tell me the story. So usually, I don't usually say, hey, tell me what brought you in today. I don't always say that. I usually say, tell me what made you decide to make this appointment. So now, like the most open would be why you brought in, why you came in today. A little bit less open is, tell me why you wanted to make this appointment. Right? Usually that'll direct them towards their symptoms and their problems that they're going through. So the open-ended question in those first few minutes is the hardest part to do for a lot of clinicians because we're trained to ask a bunch of questions. We got to listen ahead of what we need to ask them about. So the hardest thing you need to do is just listen after that. Because what's going to happen is the patient's going to start spilling their guts. Oh man, this has been going on and I don't know what to do about it, and my dog died and this happened and I've been so depressed and I'm about to lose my job, and you're listening, you're like, holy cow, there's so much going on, but that's kind of what you want. And they'll say stuff that's incomplete a lot of times, and you want to jump and ask more questions about it, but you want to refrain from doing that. Here's why. In your head, we talked about having a framework of what you're trying to do in your visit. And this kind of goes back to the first part of your rotation, okay? Where I kind of describe how to approach your studying. And there's a reason to approach it this way. Let's zoom back out for a second. In mental health, the one thing I love about it is that the information that you're trying to learn is finite. And if we look at our diagnostic things that we can diagnose, that's the worst possible way I can say that, is everything's going to fall into categories. So you got your mood disorders, you got your anxiety disorders, you got your psychotic disorders, and you can do it in any order you want to, substance abuse or substance use disorders. I got my childhood and developmental disorders. So that would include your ADHD and everything like that. You get personality disorders, and so on and so on and so on, right? And then, of course, with your mood disorders, you have your highs. So that'd be your bipolars and things like that. And you got your lows. That's all your depressive disorders, major depression, seasonal affective disorder, et cetera, et cetera. So I teach you guys to study this way because when they tell the narrative, what you're hearing is what category that fall in. Blah, 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 blah. I'm so sad. Okay, mood. Blah, 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 blah. I can't sleep. Okay, God, that could be several of these, right? Because what you're trying to do is you're developing a differential diagnosis based on what they're telling you. But if you don't have an organized way to think, you can't capture everything they're saying. You're going to forget, right? So as they talk, it's almost like I'm imagining like the words are coming down and it's going to fall into a category. And the words are going to come down, that falls in this, I'm paranoid. That could be psychosis, it could be PTSD. Blah, 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 blah. I haven't eaten in 3 days. That could be eating disorder. That could be severe depression. That could be some type of phobia. So in my head, I'm thinking like, what could this be? What could this be? What category is it falling in, potentially? Because that's going to tell you what follow-up questions to ask. And all you're doing is you're going to listen and you're going to jot down some of your thoughts in the margins of your paper or your notes or something like that. I encourage you guys to use AI to transcribe your notes so you can completely focus on your patient, right? So the patient's going to tell you your narrative and you're going to listen until they stop giving you meaningful information or the time starts feeling like, I got a lot more stuff I need to ask, okay? Depending on your setting, a lot of your patients will be able to give you their story enough that you can kind of figure out what the diagnosis is. So they'll say, blah, 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 I can't sleep, blah, 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 I'm really depressed, blah, 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 I can't concentrate, I'm about to lose my job, blah, 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 I don't enjoy anything, I got 4 symptoms. And they don't say enough to give you criteria. Now I know I just got to ask one more depression question to get criteria. So what you're doing as you're gathering this interview, you should be able to ask enough questions and or hear the narrative enough from the patient that they meet diagnostic criteria. So if you just let them talk, a lot of times, man, for about 6 years, I've been sad. All right, it's been more than 2 weeks. I got it. See what I'm saying? So they're going to give you criteria if you listen. And if they don't, then you know only got to ask a few questions to kind of get criteria. So what's going to happen is, let's say the person's talking, they give you this many mood symptoms, and they give you this many anxiety symptoms, and they give you no psychotic symptoms, and they give you some clues for substance abuse, and they don't have any of this and any of this. All right, cool. This patient likely has some type of anxiety disorder as their primary. They probably have symptoms of, I'll put bipolar here. Now my only questions I really need to ask them coming down that funnel, now I got to ask more closed-ended questions specifically about what they left out or what they already said. So now I'm going to ask questions more like, and I always use a format of reframing what they said and then asking them the question. That keeps you from asking checklist questions. Like I see students do this all the time. Do you have problems sleeping? How many hours of sleep do you get? What medicines are you on? And it makes the patient not talk. They give you, small answers, and it destroys rapport. So what I'm doing instead is saying, you said earlier that, you've been struggling with depression for 6 years. I'm sorry to hear that. Show empathy. I know a lot of my patients who have depression also struggle with, suicidal thinking. So now I've demonstrated I listen to you. I've showed empathy. I've normalized the problem. A lot of my patients have this. Then I ask the question. And I only ask one question. So my question might be, have you struggled with suicidal thinking too? Because that's a sensitive type of question some people want to answer. Yes, I've had that. So what you don't want to do is ask run-on questions. A lot of my patients, when they're depressed, they have suicidal ideations. They don't enjoy things. They don't feel like eating. They have a problem concentrating. Has that happened to you? Patient's not gonna remember all that. They remember one of those things out of there, and they're gonna leave out the most important thing that you need from them. So, be in the habit of asking one question at a time. Be in the habit of normalizing things. A lot of my patients really struggle with, sexual dysfunction with antidepressants. Has that happened with your meds we prescribed last time? Normalize it. Right? Or if you don't want to do it every question because it gets redundant, or you summarize what they said. Ooh, it sounds like, you've had this problem. What about this problem? Right? So I always ask my questions with a head on it. That makes sense? Like I'm gonna frame the question with something, and then I'm gonna ask the question. I'm gonna give it context each time. Because to me, I feel like that makes it become more conversational instead of asking list questions. To me, the sign that you mastered the interview is that the interview looks like a conversation, like someone doing a podcast. It looks like a conversation. Like we watch a podcast, Joe Rogan's not like, so do you believe aliens exist? Do you believe Bigfoot exists? Like he don't go through a list of questions. He's having a conversation with him. That's when you have mastered an interview, when it looks like a conversation just happened. But you gathered all the information that you want. All right. Now, here's some things to avoid. In my opinion, I think it's important to avoid being judgmental. Like, don't be judgmental of the patient. Right? So to do that, you have to be able to regulate your emotions and regulate your body language. Right? So if, a patient comes in and they're like, I've had 300 sexual partners. You don't have any type of reaction to that. You don't be like, wow, that's a lot of sexual partners. You don't want to say that because it's going to close them down later, potentially. Or it might hype them up because there's a reason they have 300 sexual partners, right? They may be proud of that. I want to have a neutral reaction or no reaction to something like that, right? So avoid being judgmental. Avoid asking run-on questions. We talked about that. Never package a question with multiple answers or multiple questions. Avoid leading questions. A leading question is a question you ask where you already planted the answer in it. Okay? So you don't want to be like, you'll lose your job if you're drinking. How much are you drinking? Oh, I don't drink. You kind of led them to say that they don't drink. Right? So avoid leading questions when you're talking to people. There's probably a whole bunch of other stuff to avoid. That's all I can think of off the top of my head. It'll come to me randomly as I'm talking. Okay. Now, I want to talk about because of our field, there's a lot of like sensitive topics that come up during your interview. And I'm gonna get back to the rest of the structure, but we deal with stuff like rape and trauma, things that involve shame and guilt, right? Violence, things that they've done to people, sexual health, and substance abuse. All tend to be very sensitive topics. So what you're trying to create is a safe space for them to talk. The stuff in the beginning helps create that safe space. If you're suspicious that you have a really, really sensitive topic to talk about with the patient, like you looked at the referral and it's like severe trauma, sometimes I try to even verbalize that, hey, I want this to be a safe space for you. I don't say it is a safe space. I say I want it to be a safe space. There's a difference. If I say it is a safe space, how do I know what's safe for that patient? What makes them feel safe? I don't know, right? I may say, I want this to be a safe space. Like, I want you to feel comfortable here. You know, I want to get to know you so I know what makes you feel safe. As we go through this interview today, there may be some questions that make you feel uncomfortable. Do your best to answer them so I can help you. But if you don't feel comfortable saying it, that's okay. We can go back to it another time when you feel more safe to do it. I think when you give that invitation and give them permission to not answer your question, they tend to answer more questions. That's what I've noticed, especially when they have trauma, right? Because they know that I'm being sensitive to their needs. It makes them feel more safe. Okay, they don't feel pressure to answer a question. Another thing you can do, I kind of hit on these already, to help patients speak more when you expect them not to speak about it, is using normalization, especially with kids, like in substance abuse, like teenagers. You know, hey, you know, a lot of kids, when they have all the stress that you have, you know, they tend to drink more, right? I don't say tend to drink, I say drink more. Like that's a normalization. That means people are doing it. So now they have permission to tell me that they drink. You see what I'm saying? Instead of just say, hey, do you drink? Do you drink alcohol? They know it's illegal. They know you're gonna run to their parents. I'm gonna normalize it. Another thing I'll do to try to make a safe space, especially for teens, is when I'm doing my confidentiality, it's a little bit different. Because if a child is doing something that's endangering their lives, and it's not suicide or homicide, you got to tell their parents. And I tell my kids that. I say, hey, when we meet, whatever we talk about is between me and you. I don't go run and tell your parents. Right? So you can talk about anything you feel comfortable talking about. But if you're doing things that is endangering your life, endangering someone else's life, I have to tell your parents. But I'll never tell your parents behind your back. I'll let you know I need to talk to them, and then we'll talk about it first. That creates another safe environment. I think of it like a nest. I'm trying to create a nest in my office that people can come into and feel safe, and they can tell me anything eventually. Right? What's up?
So with pediatric patients, let's say you have to tell their parents, but they don't want you to tell their parents, and then you're in this dilemma where like, well, I don't want to lose trust in this patient, but I also have to, you know, let their parents know. So what would you do with that situation?
I think when you build a rapport in the beginning, you set the expectations in the beginning, and they already know for a fact that you're going to talk to the parents, and you're going to tell them about it. I think if they know you're going to tell the parents, sometimes they don't share it with you yet. Because I already told you, I'm going to tell your parents, but I'm going to talk to you first, and we'll find a way to talk to your parents together. Okay? If they know that for a fact, they're probably not going to tell you yet until they feel completely comfortable with you, and that's okay. Because I need to build a relationship so they keep coming to me to trust me enough to tell me the stuff that's actually going on. Right? However, there will be times when it's like, oh man, you're doing what? Okay. You know, I think that's really dangerous. Let's talk about that. You're going to talk to them, et cetera, et cetera. And then, what do you think your parents would say about that? Oh, my parents will kill me. Oh, okay, I understand that. Well, if you keep doing this, you're going to kill yourself. I really think that we need to keep you safe. You know, we need to discuss this with your parents. It's more of a gentle landing. Because you got an obligation to keep that patient safe, so it don't really matter. Honestly, it ultimately doesn't matter if the kid doesn't want you to tell them. You got to tell the parents.
Right.
Like, for example, if you got a teen and, you know, they're smoking cocaine every day or something like that. If they're not imminent risk to die, I may say that to tell the parents later. But if they're doing something like they're driving the car 200 miles an hour every night, street racing, they're gonna kill themselves. You gotta tell them.
Mhm.
That's my opinion.
Mhm.
Okay. So I'll talk to the patient and try to segue to the parent. So there's not one easy answer. But the better rapport you have with the patient, the better relationship, the more you forewarn them, the easier it is to kind of have that conversation.
Mhm.
If you really want to destroy the relationship, just go tell the parents behind their back, and then the parent go fuss at them about it. Oh, it's over now. They didn't tell you nothing else.
Mhm.
Okay. Here's something else to be mindful of is trauma. So one thing I try not to do in my initial interview, remember this is just your first interview, is I'm not trying to re-traumatize the patient. So a lot of times people have severe trauma, they don't want to tell you their whole trauma all over again the very first time you see them. So usually I'll give people permission not to tell me all the details of the trauma. So I may say, I might be doing my PTSD screening. I'll say, I use that normalization. Unfortunately, we live in a fallen world. A lot of people experience a lot of bad things, car accidents, acts of nature, violence against each other, rape, etc., etc. Have you experienced any trauma? I'm sorry that happened to you. Empathy, right? It's not important for me to know every detail about your trauma, but it does help me make some treatment decisions to get an idea of what happened. Can you tell me, in general, what happened to you? I just wanted the bird's eye view because I just met you. You don't need to tell me every little detail about what happened. I just need to know, was it sexual assault? Was it physical? Was it a car accident? I just want to be in the ballpark of what happened. Because I'm not trying to re-traumatize the patient while I'm talking to them. I'm still building rapport. Over time, I'm going to dig out all the details of what happened if I need that to make a treatment decision. Okay. So those are some things. Substance use, we got to kind of talk about it just being non-judgmental about substance abuse, normalizing its use, trying to get quantities of what it is, etc., how they're using it, because that's important information. Let's talk a little bit about we talked a lot about how do you get information out of the patient, how do you get reliable information, how do you redirect the patient. I want to talk about how you do a hostile patient, because you're gonna run into hostile patients, people that's angry and they use hostility in different ways. One, that people can, just actual anger, raising their voice, getting irritated, cursing at you, things like that. Or they can use silence as a weapon. I don't want to be, my mama made me come here. I'll talk to you the whole time. Okay. People over talking and avoiding what you want to talk. That's I don't know if that's hostile, but sometimes patients will over talk you. You can't even get the question out. Just gonna over talk you. It means something, but how do you manage that? So let's talk about those one by one. An angry patient. If someone is angry, they're raising their voice at me, they're mad at me, I know I ain't doing that wrong to them. So this is another opportunity to manage your energy. So if someone's energy is rising, my energy is going to be still. I'm going to be real still. And I'm going to use my voice as a way to help that patient. So I'm not going to raise my voice. What you're not going to do is talk to Dr. Bull. You know what I'm saying? I'm not going to do that. So I'm going to try to be real calm with my voice. I'm going to lower the pitch of my voice. Right? And I'm going to slow down the cadence of my voice. I'm going to acknowledge their feeling. And I'm going to acknowledge my understanding of why they're upset if I know what it is. Right? Now, I understand that you're really upset right now. I would probably be upset too. Right, so I want to acknowledge them, acknowledge their feelings. I want to give them an opportunity to be heard. I want to make this right for you. I just want to listen. You mother effers, no one ever listened to me, blah, 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 blah. But I'm here to listen, to hear what you have to say. All right. So a lot of times people, when they're angry, they just want to be heard. Or they're trying to cause conflict and they want you to get upset too. So I refuse to get upset. And then there's just people you just can't reason with. You cannot reason with an unreasonable person. So it's okay to end the interview if you don't feel safe or you see that this is not a situation that I can attenuate. So that kind of speaks again to where you're going to seat your patients in the room. So you never want to seat yourself in a position if you expect some type of confrontation or you got. I come into your appointment. I'm a big guy, and you looked at the record that said anger outbursts and violence. Don't sit here and let them sit to block the door. Because if you have to abort the thing, you blocked in. You can't get out. Right? So you want to organize your office in such a way that you can escape if necessary. Right? So using hostility, I'm just kind of using my voice. I'm being really calm. I've already built rapport. I've already been super kind to them. All right? So when they're angry, you gotta realize they ain't really mad at you. And because you built rapport and you show empathy and gratitude, they're less likely to strike out against you. Right? They're mad about something else. And you just want to address it. So Dr. Schultz, one of my mentors upstairs, he had a patient pull a gun on him in a session. And the patient was pissed. And the guy had the gun in Dr. Schultz's face, like this. And Dr. Schultz said, cool as a cucumber. I was like, Doc, what did you do? Like, I would have Krav Maga that guy, you know what I'm saying? And he was like, I understood that he wasn't mad at me. I didn't even really know him. What came to find out is Dr. Schultz was treating his wife, and the husband was abusive. And Dr. Schultz was working with the wife to help her realize like that she has value. And she stood up to him. And he was mad at her because the wife wanted to separate. So the way he dealt with that is, like I just said, using his voice, acknowledging his anger. And he asked him the question. He was like, are you angry at me? Or are you angry at the wife are you angry at the fact that your wife set a boundary with you? And the guy thought about it and put the gun down. Gun wasn't loaded. But I was like, I don't know if I could have did that. I probably would have pooped and peed. I would have panicked.
Mm-hmm.
But, you know, you can't outrun a bullet. So the only thing he had was his voice and acknowledge the guy. And, you know, ask him a question. Sometimes when people are angry, sometimes a diffusing question can be helpful. We don't got time to go through all those. Okay.
Sorry, in a situation like that, after that happens, if it ever happened, God forbid not, what would you do? I mean, what did the doctor do? Did he report that incident to the authorities, or?
I think,
Because that's assault, pretty much. I mean, I don't know how it is
I think you can.
in South
I
Carolina,
mean,
but
you could report it.
if somebody pulls a gun at you, that's brandishing a weapon. I don't know how it is here, but.
You could definitely report that
Okay.
if you wanted to.
Right.
But it depends on, in my opinion, it depends on the situation.
Right.
Like, I feel like if that had happened to me,
Uh-huh.
and I was able to resolve it and understand the person, I don't know if I would report it.
Okay.
Because he wasn't angry at me. He just reacted to a situation he didn't know how to handle it, and he handled it the wrong way.
Okay.
Versus, man, this person is antisocial.
Mm-hmm.
Ain't no reasoning with this person. He might come back and try to shoot me another time. I'm definitely reporting that. I've had patients in here that have brought guns. We treat a lot of vets. I had a patient. He sat down. He pulled a sidearm, put it on the table, threw his feet up on my table, had a gun right here in this thing. And I was like, what is happening? So I leaned into it. Cool. Can I see your gun? Leaned into it. All right. Oh, that's a nice gun right there. That's cool. I'm like, is it loaded? So I need to know if it's a loaded gun or not. No, it's not loaded. Can you clear it for me? Okay, cool. Now I know I'm not going to get shot. I leaned into it. Then I said, you know what? You know, we don't allow, weapons in the office. It's cool that you felt comfortable bringing one in here. Please don't bring it again. Oh, my bad, Dr. DeVos. I didn't know. Da-da-da-da-da. I'm like, you strapped up. But it's just the way you handle, the way you react. You can kind of deflect. I mean, it can be scary. There's definitely some scary times in psychiatry. Like people will bring stuff and knives and weapons or they're violent. But I promise you, the energy you put out, that's what you get back. So if you're addicted to them from the jump and they get mad, they're more likely to try to beat your tail. Versus people don't like to beat up nice people. They don't. Okay. And then stay in the gym. You never know when you got to run. All right, let's move on because I don't want to go through too much. We got to bring this ship home. All right, so we kind of talked about want to talk about a little bit about listening. So we're talking about, hey, don't just hear the patient, listen to the patient. So there's a few things that I like to point out. When you listen to the person, you gotta listen with your ears, you gotta listen with your body, you gotta listen with your eyes, right? So eye contact is important, but I usually don't overdo eye contact because it comes off as confrontational, right? Leaning in, so you want to show signals that you are engaged with them. So when people are talking, like leaning forward, nodding my head, showing empathy with my face. Oh, that sucks. And I want to, whatever they're feeling, I'm trying to allow myself to feel a similar feeling so I can emote appropriately. So if someone says someone died and this bad thing's happening, I want to show like sympathy, like, man, dang, this really sucks. If that was me, I would feel this way. Because I'm trying to reflect their emotions with my body language. All right? That's how I'm listening. I'm listening with my body language. All right? I'm listening with my voice. So if they say something, I'm so sorry that happened. Tell me more about that. All right? And I'm showing compassion through my small comments I'm making to make sure they keep talking, but they know that I'm listening. Another thing you can do to make sure that you're listening is summarizing or paraphrasing what they said. So that's when I use my pause button. They tell a story and I need to redirect them or something like that, but I want to, should I listen? I say, this is a good pause point. What I heard you say is blah, 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 blah. Summarize, paraphrase. And I'm going to lead that, and I'll always lead that into a next question. Can you tell me now about blah, 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 blah? Right, so now they know they listen. Another thing you can do is what's called meta messages. So a meta message is like commenting on the unsaid. So if someone says, oh, my mom was so abusive and this happened and that happened and yada, 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 and she sucks so bad and blah, 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 blah. And then in the same breath, they say, oh, I live with my mom and I just spent $100,000 to do this and da, da, da. It's not, and it's incongruent. And she didn't mention a why or something like that. I may paraphrase and I may ask them about that gap of information I have. So she didn't say, well, how'd you get to the point that you have a relationship now with her with the things that she's done? Like I want to comment or listen to things that's unsaid, because a lot of times there's a reason why it's unsaid. So I may paraphrase, I noticed that you didn't mention, then ask a question about it. Right? So those are some ways you can show that you're listening to a patient. Cultural differences, so that comes up a lot. One mistake I used to make early in my career is assuming that because I'm black, I understand you because you're black too. I think a lot of people go through that, right? I'm white, you're white, we understand each other. I'm Puerto Rican, you're Puerto Rican, we understand each other. In some ways, yes, that's true. But in a lot of ways, you can't assume that you have the same life experience. So I try not to make cultural assumptions about a person. Like that's real easy to do, is make an assumption about somebody based on their culture, especially if you have similar culture. Or it's even worse, you make an assumption about somebody else's culture that's not yours. You're assuming because they're white, they think this. Or you're assuming because they're black, they think this. Like, be really self-aware about your own cultural biases that everybody has because of the society we live in. So just check those things at the door. Let's see, what else comes up? All right, so let's talk about how you get through the rest of the interview. So honestly, we just spent almost an hour just talking about getting through your HPI. All right, so here's a quick summary. Be nice, greet, shake hands, observe, regulate your body language, give the patient a cue so you know that you have the opportunity to pause them and shepherd the interview. Ask open-ended questions, listen, see what type of things they give you, and what categories their symptomatology falls in. Ask follow-up questions based on what they left out and incomplete things that you need to know, right? And then you'll have a very robust narrative and story, and you'll have a really good feel about what's going on diagnostically. Now I need to get the background information. That's the rest. That's your past psych history. That's your past medical history. That's your social history, your family history. All of those things are important. So here's the way to think about the whole interview. The first half is the narrative, greeting, all the other stuff. What that does is gives you the diagnosis. The second half gives you the information you need to treat. That's why it's important, right? So I like to be really meticulous about their past history. I usually start with their past psych history. Have you tried to do this problem before? What meds have you tried? Who have you seen? What was most effective for you? Right? I want to ask a lot of details about it. I need clues about what I'm going to do to help them. Right? So let's kind of walk through these right quick and what you get out of them. So if we do past psychiatric history, that will include things like medication trials. That will include hospitalizations, previous outpatient care, other things like kind of like their other things they've attempted to help the problem. That'll be like counseling and yoga and everything else they've tried to solve the problem. That's what goes into their past psych history, in my opinion. Okay, there's probably a little bit more I'll think about. Some people separate this out. So I like to do like their risk assessment history. So, have you tried to commit suicide before? What did you do when you did it? How many times have you tried to commit suicide? What was the worst thing that happened to you after you had a suicide attempt? Oh, I woke up in the ICU 10 days later. All right, I know this person is serious. So they tell me they had suicide, I'm gonna take them serious. First, someone says, I don't know, I had a suicide attempt, and I waited for someone to care, but no one else cared, so I just continue playing video games. Okay, that probably wasn't a very serious suicide attempt. So I like to ask details about this. Now, here's what it's gonna tell you: the med trials that they tried before, you want to know what they tried. Did they get optimized in the dose? Did they have side effects? What was the outcome? That's what you want to know about the meds. Because what that's going to do is going to narrow down what you're going to try with the meds. And you're going to look for patterns. So, if, for example, I want to know, have you mostly tried SSRIs? Have you tried dual agents? Have you tried augmentation strategies? Because I'm thinking through, what is the normal algorithm of treating this? What have you already tried? All right? So basically use your med history to rule out what to not do again, but to give you clues of what might work in the future. That makes sense? Okay. Hospitalization tells me about their acuity. How sick is this person? If I see a patient and they have 30 hospitalizations, that person is a very sick, complex person. If I have a person that has 5 hospitalizations, that means something very different. Versus the person who had 5 hospitalizations, the last one was 30 years ago. That's very different from the person who had the last one 30 days ago. So I want to know, when you were hospitalized, how long were you there, what were they treating you for, et cetera, because it's giving me a clue to their acuity right now. I want to know what their previous outpatient care. I want to know how experienced you are in this. Have you only been getting care at family practice level? Okay, so you're probably not as sick, or you didn't have access. Versus, either you're my sick psychiatrist, nobody can figure it out. Better eat my Wheaties, right? It's going to be a tougher case, right? What else they've attempted to solve the problem? So now I want to know, like, have they only been trying meds? Have they even ever did sleep hygiene? Have they ever even, tried to change their diet or gut? So you're looking for interventions based on what they've already tried and what they haven't tried. Because I want some solutions at the end of my visit. And then your risk assessment kind of fits with the hospitalization. Like, I want to know, did you commit suicide? Try to commit suicide. Well, if you committed, you wouldn't be here. But have you tried it? What did you do? Because I want to know what your capacity is. Like one of my patients, one of the few patients that has my phone number. Okay. His suicide attempt is he took a knife that's used to carve up fish. And in the suicide attempt, he took it and he cut himself from ear to ear. And he has a scar all around his neck just like this. So when he tells me he's not doing good, I take him seriously, even though it happened, decade and a half ago. Right? I take him very, very seriously because he had a very serious suicide attempt and he expected it to be done with himself. Right? So knowing what they did and what the outcomes give you an idea of the risk. The best predictor of the future is the past when it comes to mental health. Okay? That's your past psych history. Other thing I want to know, we don't have to do them in order, so y'all can throw them out for me, but the next one's going to be, their past medical history. What is that going to tell me, right? So I want to know, do they have any acute or chronic diseases? Acute disease is going to be like, all right, cool, there's this acute problem exacerbating their mental health. You know, oh, I got COVID. I had long COVID. Now I'm having all this really bad depression. I've never been depressed before. Okay, acute medical illness may be the reason why you feel this way. Okay. I want to know what the chronic illnesses are. The big ones around here are like diabetes and hypertension and heart disease, because that'll affect what I prescribe to them. Right? So every piece of information is helping me make a treatment decision. So, oh, I'm pre-diabetes. All right, well, I guess no Zyprexa for you. See what I'm saying? I need to rule out what I can possibly prescribe, and I get it from these information points. High blood pressure. All right, I need to be careful with stimulants. You know, cardiovascular disease. Okay, I need to make sure that, I don't know if this causes QT prolongation. I probably don't want to give it to this patient. Or they may not be a candidate for ketamine because they can't handle it. Right? So each thing means something. I'm going to rule out what I'm going to do with this stuff. Right? I also want to know about the brain. Have they had concussions? So I'm looking for anything that would have affected the brain that may be an explanation for their symptoms. So concussions, traumatic brain injuries, stroke. You know, my mama dropped me on my head when I was a baby. Like, since I'm a child psychiatrist, sometimes I'll ask, especially with kids, prenatal history. Well, did your mom drink while she was pregnant? Was she on any drugs? Did she get ill during the pregnancy? So I want to look for any possible insult to the brain, because I'm looking for an explanation of why the patient is like they are. Oh yeah, when I was 2, I almost drowned in the pool. I was, you know, technically dead for. I got a patient. This is a true patient. I was, you know, dead for 30 minutes, and I got brought back. Oh, you had an anoxic brain injury. See what I'm saying? That would explain why you have all these problems. So you're looking for any potential insult to the brain. I also want to know, is there any medical thing that may compromise your ability to take the meds? So I want to know what's going on with your liver. I want to know what's going on with your kidneys, et cetera, et cetera. Because most of the medicines are metabolized through these pathways. All right, so I want to know about that. I want to know your surgical history, because that means you were pretty sick if you had surgery, or pretty injured. I need to know that. What happened? Oh, I had a surgery to fix my femur. How'd you break your femur? Because I wouldn't have come up because you came to me about depression. Oh, I got a severe car accident. I was unconscious. I got airlifted to college, MUSC. Oh, you didn't mention the brain injury. Oh, that makes sense. All right, I went on the surgical history. I need to know what allergies they have, so I don't accidentally prescribe them something that they're allergic to. Okay, that's your past medical history for the most part. Okay, give me another section. What else you want to talk about?
Social history.
Yeah, I'll say social.
All right, let's do social history. What does the social history tell you? So the good thing is you don't just treat with medicines. The social history kind of gives me an idea of functioning. Who's in the family? What's your household look like? All right. What's your employment? How much are you working? How many hours are you working? What's your socioeconomic status? This can give me an idea of your access to care, right? You know, do you have a lot of support? You're suicidal, and then you go home, you got an abusive husband. Oh, God, I might more likely put you in the hospital versus a person like, we have extended family in the house. Everyone's so supportive, and my mom sits in my room all night with me because I've been struggling with depression. They have a lot of support. I may be less inclined to be aggressive with things like hospitalizations because you got a lot of support. That's what the social history is telling me. Oh, I'm super poor and I'm only here on a grant from my church. Okay, I probably won't be prescribing medicines that are expensive because you don't have resources. So social history tells me, give me an idea of what I am capable of recommending to you based on what your social network is and what your access to care is. Okay. Substance use history. I like to do substance use history separate from the social history. Mostly because I like to get really detailed about substance use if that's part of the complaint. If it's not part of the complaint, I may just kind of ask them some brief questions. All right. So once again, you want to know what substance they use, how old they started, what does it do for them? Because that gives you clues about diagnosis. Oh man, I smoke weed every night because I can't get my mind to shut off. I be worried about this. Okay, you have anxiety. That's probably why you smoke. Or I can't sleep, so I smoke weed every night. All right, I need to fix the insomnia. All right, so I want to know what what the substance does for the person. So it may give me a clue of what I may try to treat therapeutic and make them less reliant on that substance. And this is an area you have to be completely non-judgmental from. And I always remind people, I ain't the police. I ain't here to arrest you. I'm here to help you. So it's important that you tell me the whole story, what you're actually doing. Okay? Because I don't want to prescribe something and you're using this and it really hurts you. All right? So I want to know how much, how often, when did you start, what does it do for you, when was your last use, things like that. So in these sections, based on their chief complaint and what your intuition is about the problem is, you may not be able to go as in depth in each individual section. But you know where to mine for the data that you're looking for, though. See what I'm saying? So if I'm like, sometimes I get to the inner narrative, I know exactly what I want to do. They told me enough. All right, I just need to validate that theory. Other times, like, there's so much going on, I don't even know where to start. Let me focus more on their past psych history, because I need to know what to do. Or, I got a good plan what I want to do, but I don't know if they can do that. Let me spend extra time in their social history, so I can get an idea of their support network and their driving history, stuff like that. See what I'm saying? That makes sense? So the purpose of knowing how to do this is know where to mine the data to get what you need to know to figure out what you're going to do. Okay? What else we got? Yeah. Family history. Oh, family history is big. I feel like I get a lot of information out of family history. Family history was the original psychogenetic testing to figure out what medicines to try. Now we can just do a cheek swab, but I feel like the family history has value. I want to know who had what and what did they do about it. Oh, my mom had bipolar. Okay, how's she doing now? Oh, she's doing awful. She's homeless. Versus, oh, my mom's super stable now. Okay, what does she do? Oh, she got stable on lithium. Oh, sweet. You got 50% of her DNA. Well, let's try lithium, right? So it gives me clues of what I want to try and what not to try. And it also gives you a clue of the trajectory of the patient. I got a patient now. His dad has schizophrenia, schizoaffective, either probably a bipolar. I think it might have been bipolar with psychosis. And dad was normal until he got into his 40s, which is kind of atypical. And then he just went full psychotic on the family. And the patient came to me late 30s with the early signs of psychosis. And I'm like, oh, great, you're on the same trajectory as your dad. So tell me what happened with your dad. Dad really had very, very severe problems when he didn't get treatment. So I was able to impress on the patient this potential where you could go, basically because it's your dad. But he didn't do this. You need to do this. And they buy in more. Right? So you want to know who had what and what happened to it. All right. Am I missing any sections we can think of? We did substance use, their family, we did social, we did substance use, we did medical. You can do a legal history. Oftentimes patients don't have it. That could be a very simple question. But also, it depends on your population. If I'm working in a substance use clinic, I'm always going to do a legal history. All right? If I'm working in the forensic unit, you're going to have a lot of information on the legal history. In an outpatient clinic like ours, we probably don't spend a lot of time in legal history, but it's a big clue. Oh, I've been arrested 16 times. I got 3 DUIs. Or I got 10 DUIs. I don't have a drinking problem. And you're drinking right now. Oh gosh, yes. So you're minimizing. So we'll give you some clues there. Okay. I think we covered most of the sections and understanding that you're mining data. But all right, how do you organize that data so that it's actually useful? Okay. So this is another one of those frameworks. Okay, and then we're going to bring the ship home. So now you collected all this data. What do you do with it? Because what tends to happen with some patients is they've given you so much information and so many different problems and so many issues you don't know where to start. Or you got so much information, it's like, what the heck do I do with that? So it's like that old adage, how do you eat an elephant? One bite at a time. So here's the structure I use to help me conceptualize a case so I can figure out how to treat the patient. And you've heard it 1,000 times. It's the bio, psycho, social, spiritual model. And I add the spiritual on here. Because everybody don't use the spiritual, I do. So when I'm doing an assessment, so this is assessment. Use of it. When I'm doing assessment, I don't write this out. I just think this through. What I'm thinking is, what are all the biological reasons that would explain why this patient is presenting the way they're presenting? So it's like, I'm thinking about things like genetics, head injury history, medications, hormonal issues that could be happening. Is their testosterone low? Is their thyroid messed up? Are there medicines, or is it iatrogenic? Was it COVID? Was it infectious? So I'm thinking about all the biological reasons that the patient may be presenting. Oh, it's polypharmacy. That's why, they have Parkinson-like symptoms. That helps me organize all the stuff they told me, so I make sure I can control what I can control, right? Oh, I probably need to check their thyroid level. I need to check their testosterone. I need to do this. Psychological, I'm thinking, what are the psychological reasons that the patient is presenting this way? They have trauma. They have, now they have this worldview. Now that their personality issues, their mommy issues, their I guess perception of their spouse, their inner voice and how they talk to themselves. I'm thinking about what are all the psychological things, the defense mechanism. This person's in denial. How am I going to overcome this denial to help treat them? You're alcoholic, but they're in denial. Right, so I'm thinking about all the psychological reasons they have the problems that they have, because some of those things will be modifiable, some not. And I'll say, okay, you need therapy for this, you need DBT for this, you need marriage counseling for this. It's helping me choose what I'm doing my treatment plan. Socially, what are all the social problems that are happening that's enhancing or detracting from this patient's life? Oh gosh, they're unemployed and they can't get disability and da 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 da. I'm thinking about, because this is going to tell you what all the barriers are to your care, but all the things outside of my office that can help them. And then spiritual, what is their world view about what happens after death? Do they have a strong faith and they would never kill themselves? Because, if I commit suicide, I'm going to go to hell. I've had these feelings, but I would never do it because I believe this. Versus, atheists, I don't believe in anything. Satanists, I've had Satanists come here. Oh, hell, Satan, that scares me. But it happens, and it affects their care, right? So I'm looking at what are their spiritual strengths and weaknesses, because it's going to help me figure out what to do. Then I'm going to use the same structure to create my treatment plan, because I only can control what I can control. So now that I identify, hey, in my head, here are all the possible things that be going on based on what they told me. Now I need to, all right, cool, I need to order these labs. I need to get these hormone levels. I need to check their liver and kidney. I need to, they had long COVID and they had this problem. Okay, I need to do this, right? So it's kind of telling you, based on your assessment, what to do about it. Oh, they're on lithium and, their hair's falling out. Let me get a lithium level. Psychologically, now this is telling me what counseling services and what barriers I may have to try to reach this patient. Oh, man, they have so much trauma. They've never done EMDR. Maybe they need to do EMDR. Or they need to do CBT because they have a lot of negative self-talk and negativism. All right? My social is going to tell me what other resources I may need. I need to refer this person to IOP. This person needs to do Spravato, but they don't have transportation. How am I going to solve that problem? Right? Because I've put it out in a structured way I don't miss stuff. And the good thing is, you don't have to do everything at once. So when I first started the patient, I may do the basics. All right, let's start with some labs. I think you have depression. Based on your family history, I think we should try this. Da-da-da-da-da. They've been in the system. You've seen 6 doctors. This basic stuff ain't going to work for you. We need to do this. Right? So I've taken all this information and distilled it down into these little core sections so I can make a problem-based treatment plan that's very structured. Right? So you can do the biopsychosocial. Some people do, like I said, problem solve. So you might identify problems. You might say, all right, problem 1 was depression. Problem 2 was, cocaine abuse. Problem Problem 3 was divorce. Problem 4 was, I don't know, mild renal failure. And you can kind of walk through and make a whole bunch of problems. That's another way to organize your thoughts from all that information you just did. That way you can say, all right, for depression, I'm going to do this. For cocaine addiction, I'm going to do this. For divorce, I'm going to do this. And you can just do it piece by piece. That helps you organize your thoughts. Because otherwise, you can get easily overwhelmed by any patient. Okay. All right, so what we did today is I walked you all the way through a full interview. I walked you through how to conduct the interview. I walked you through how to get their background, history, and what to do with all that information. I walked you through how do you organize your thoughts when you're doing your assessment. And I walked you through how to use that assessment to do your treatment plan. One thing I didn't say specifically is how do you diagnose. That's easy. If you did your interview the correct way, you were already thinking diagnostic in the narrative part. You were asking questions to make sure that they meet criteria for what you think it is. So here's the thing. I always use this analogy. When you see a little web-foot animal walk in your office and it has feathers and it goes quack, 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 and it has a bill, you take a cup of water, you pour it on his back, and it beads off and rolls away, and you don't go, check, bill, what feed, feathers, quack, 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 diagnostic criteria of a duck. Like, you don't do that to recognize a duck. You just see the duck, like, oh, that's a duck. What'll happen as you treat patients, they'll start talking, oh, that's depression. Oh, that's PTSD. Oh, that's this. But you still need to gather enough information to meet criteria. Because when I come behind you and read your note, I should be able to read your note and say, oh, okay, I can see how they diagnosed him with depression. Or, oh, I can see how they diagnosed him with schizophrenia. It shouldn't be like you got incomplete information and I can't come to the same conclusion that you did in your note. You got to meet criteria. Okay, that's my opinion. All right. So that is, in a nutshell, as much as I can dump into about an hour of your time to teach you how to conduct a very thorough interview and then use that information to start the process of treating a patient. Okay. I hope that was helpful for you.
Yes, it was.
Any questions? You don't have to have any.
I just have, hopefully this is part of what you're saying, but even like patients who come in and like you say, you're trying to get out of a situation. So even like when I was with Jeanette and we had that patient that one day, and of course.
What happened? What happened?
And I think we actually tried to find you, but I didn't know if she ever did find you to talk to you about
She
it.
did.
But he was just, the way he was speaking, it was getting to a point where
It's like a big black guy.
It was a black guy.
I remember that
Kinda
somebody came to the
tall.
window, was kind of weird.
I wonder if it was him.
He had a black shirt on,
Well, I don't even
like a
remember
skeleton
now.
or something like that.
I don't even remember now. And he was, you know, like cursing and just the way how he was. It was almost like he was manic, but then like she would ask him about, do you want to hurt people? And he's like, I just want to go out and like kill someone. And I just want to hurt someone. Like if anyone tries me, and you know, just trying to get that out of him. Like, so are you going to leave here and hurt someone? I don't know. I mean, if someone tries me. And you could tell it was just getting to a point where you're like, oh no. And like after the fact, she even was saying, she's like, because also you were in the room, so didn't want to, you know, escalate it any further to the point where he was even, they were talking about coming back again. And I could tell that she was not inclined to him coming back because just the way how she was answering, like dodging the question. And she was like, well, they will let you know. They'll let you know the minute he left. Like she locked the door and whatever. But you know, things like that where I'm thinking if you're the provider, when we say about how you're sitting and things like that, but how do you get out of those situations if, for instance, a patient does want to do something? Like I know we speak about those, but I've never heard of, like how would you actually get yourself out of that situation to not get potentially hurt by a patient?
I think it starts with, like I said, trying to build rapport early. Because he didn't say he wanted to kill her. He wanted to kill somebody else. He didn't have any specific plan.
Yeah.
It's not like he was being provocative. And he may have been hypomanic or manic or something. That's
Yeah.
possible.
But I mean, like
Okay.
if
If he had escalated to being aggressive towards the provider, step one is try to de-escalate. Right? That's step one, if you can. Sometimes you know this person got a bad intention, they're gonna try to hurt me, then you need to, we have cameras in every room. So here we got cameras. That helps. So if someone's like get aggressive or something like that, hopefully we can come in the room and help with that. I think one, you want to ask for help. So if I was in that room and the patient was getting more and more aggressive, I would have got my phone, I'm gonna send a text to the front office. Hey, I got an aggressive patient in here. I'm trying to de-escalate it, but be aware I got somebody here. Okay. As soon as I started doing that, I'm gonna ask for help. Two, I'm gonna use the techniques we talked about before, which is using my early therapeutic rapport to try to de-escalate the patient. I want to hear them. I want to acknowledge how they're feeling, and see if I can use my voice to de-escalate them. Okay. Usually, I like to be eye level or slightly below eye level with the patient. So if the patient stands up over me, I don't like the patient stand up. I'm gonna try to create space. Right. Right. I may say something like, it's clear that you're upset, and I don't want to be uncomfortable, and I don't want to make you feel uncomfortable. I'm just going to back my chair back a little bit so you can continue to say what you need to say. All right? Or, I'm trying to create space between me and the patient because I don't want to be confrontational. But I also don't want to be like super passive either because then they want. It's like a wolf and a rabbit. I don't want to be the rabbit, right? So for me, it's also different for a male than a female. So for me, I'm gonna try to create space. I'm trying to de-escalate my voice and my ideas. I want to make sure they're heard. I want to alert and make sure people are available for help. And I'm going to be at eye level or slightly below, but not way below. And I definitely don't want to stand over them. Right? So if I need to stand up, I might say, you know what? I think I'm going to stand up to finish our conversation. But I'm going to keep space. I know I need to get out of there potentially. All right? Now, I never want a situation I have to put my hands on the patient. Or the patient has to put their hands on me, but it happens. And because people are people, right? And you want to do everything you can to avoid that situation. And if you do have a kind of physical confrontation with the patient, your only objective is to get away from the patient and keep yourself safe. It's not to hurt the patient, right? Because it'll come back to bite you. So I know how her office is set up. It's not ideal because she's blocked in that room, right? So I think only thing she could have done in that situation, if he did actually get aggressive and try to hurt her, is ask for help. I'm just scream for help. Don't be afraid to scream for help. There's somebody in every room. I'll come in there and lay the smack down. It's okay. That's happened before, not here. Like in an inpatient setting, I had a situation multiple times. Had a patient at Georgia Regional Hospital in Atlanta, outside Atlanta, and the patient was psychotic and punched one staff, he spit in another staff's face. They was trying to calm him down. He slapped another one, and the person fell. Said, "Oh my God!" And the guy was walking out, and he saw me. He was like, "Oh, you cool?" And he went to the next person and hit the next person. So there's some power in having a rapport with the patient. But there's been times when the patient actually put their hands on the patient, on another staff member. I never had somebody put their hands on me. It's fortunate, right? But honestly, I don't know the full answer because what's going to happen, your survival instinct will kick in. And if I got to chop somebody in the throat, I just got to chop somebody in the throat, to be honest. So I'm going to cut that out of the video. But but obviously, you just never want to get to a situation that escalate to that. And it's okay to say, you know what, it sounds like you're really upset. This may not be the best time to talk. Let's end this interview. Okay. I'll allow you to do here. I'll allow you to walk out. No issue. And if you're worried they're going to go out and hurt somebody, let them leave. Then call, hey, I just had a patient. His name is this. This is his cell phone number. Here's where he lives. He said he wanted to kill somebody. He wouldn't give me specifics. He left my office. And I alert the authorities and let them handle it. Okay? So that's how I typically handle those situations. But I promise you, if you build strong rapport in the beginning, usually unless they're really significantly mentally ill, they won't hurt you. And a lot of times, if you show them dignity and respect and kindness, they're way less likely to try to hurt you. Okay. So that's my opinion on that. Any other questions? All right, cool. Let's take a break. That's what we'll talk.